Okay, so I'm going to talk about event-related potential analysis in healthy and spinal cord injured individual, and show some results. We are developing protocol of measurement and signal processing to analyze and pinpoint changes in the spinal cord and the brain as a result of injuries in the spine or in the brain. This is an overview of my presentation, and I think I'll go just quickly through this. This slide is just to show you what I'm talking about. So we are talking about the injuries in the spine and in the brain, which lead to spasticity in the lower limbs, and this diminishes the ability of people to move and walk, and that we want to treat. We are applying a method called TSCS, transcutaneous spinal cord stimulation, which aims at stimulating at the level of T11, T12, the sensory fibers, in order to influence the neural network in the spine at that level. The neural network, we believe, controls the motor signals down to the muscles. Our aim, we look at both EEG and EMG during this treatment. And just to refresh your memory, we have the motor cortex here in the middle and the sensory cortex. And the organization of them both is that you have the lower limb at the top of the skull for both of them. And for both of them, you have a crossing over. I forgot my glasses. So you have a crossing over of the signal path at the position on the spine, and so they're contralaterally organized. Okay? I hope I get it. Now, the main thing we are looking at, or where we are influencing, is this monosynaptic reflex. You know, when the spindle is... So, we are talking about spinal cord injuries and the communication between the brain and the body. This communication is, of course, diminished depending on where on the spine it is the injury is, or where in the brain, or how much of the brain is influenced, and whether we have a complete or incomplete injury. Now, the main brain injury, stroke or traumatic brain injury, we have in Iceland about 150 persons with stroke every year. We only have about like 7-8 persons with spinal cord injury every year. So, but this causes a burden on the healthcare system, which we would like to diminish if possible. And in both cases, we have spasticity. 80% of the spinal cord injury individuals develop spasticity, and about 30% of the stroke individuals. Now, I think I'll just go quickly over this. The state of the art of the treatment is manifold, medical, physiotherapeutical, and surgical. We are going to use transcutaneous spinal cord stimulation, or looking at transcutaneous spinal cord stimulation to improve the gait function. this activates the spinal circuitry and is non-invasive. It has been shown in the epidural stimulation, originally by accident, that this could diminish or abbreviate spasticity in lower limbs. So this stimulation is transmitted through the dorsal roots, and the recent findings indicate that it could be possible to use this for stroke patients, which we have not been able to do in any convincing way up to now, but we have been able to do that for spinal cord injury patients. Okay, we are looking at EEG, we are looking at the brain waves, mostly the beta and gamma bands, also at the alpha, and I'll talk about that later. If you look at the event-related potential, do I have to explain that? No, everyone knows what that is. Okay. So just to remember then, P1 is the first peak, the second peak, first positive, first negative, and so on, peak, and they have a different time scale. This is the two methods we used, the event-related desynchronized signals and the event-related synchronized signals. Okay, I'll go fast through this. This is the... But the aim of our work is to establish a methodology, protocol, and take measurements, to develop a pipeline for signal processing, and investigate the latency of brain potentials, frequency of brain waves, and muscle responses in relation to the brain and between the groups we are looking at. And gain information on the consequences of damage of the central nervous system. Okay. This is to give you the overview of the next part. So, what groups are we looking at? We have two age groups of healthy subjects. So we have young people, students at the university, 20 to 30 years old. We have healthy elderly, 50 to 63 years old, only 4 up to this slide. We have 23 of the younger, and then we looked at one spinal cord injury with an injury between C6 and C7, and we have one patient which had a spinal tumor between T1 and T4, which was taken away in a surgery, but there still remains a tumor, so it was not taken all, and he seems to be able to live with a tumor, but he has spastic, and his moving ability are diminished. Now, just to look at some numbers, this guy, the height, maybe the weight is more interesting. So the average weight of the young people were 76 kilos and body mass index of 24. Average weight of the healthy elderly were 87 and body mass index of 28. This one, 60 years old, is very light. He has lost a lot of body mass, lost a lot of muscle mass in the legs, and has only a body mass index of 20. And the second one, but he has a normal values. Okay, and this is our equipment. I think I'll just skip this. This is our measurement protocol. We start with a baseline where we have a EEG cap with 64 electrodes, although in this study we are only using 7 of them. We take a baseline in 2 minutes, then we put on EMG electrodes on the lower leg. We stimulate the patient, and we look at both. We measure both the EEG and EMG, and we then test them with patellar. We test them with a hammer hitting of the patellar tendon. And the stimulation is done this way. We put an electrode at the gap between the T11 and 12, and the other electrode down at or below L5. And and then we do this with we hit with a hammer. The hammer is a reflex hammer that is has an electronic in it and is synchronized with the signals, both the EMG and EEG. Now this is the signal processing path. I think I'll not go through it in detail. Filtering, synchronization. The main thing is maybe just the statistical, the averaging of and getting the event-related potentials, and then to make a time frequency analysis. And results and discussion, I think I'll just, we can state this. Signal processing pipeline is one of the primary outcomes of this work. It functions well and provides satisfactory results, but we need more information on the physiological part of the. Now, key findings in this group of patients. We have been looking very closely at the CZ electrode as it is located over the sensory motor area. We did this for the age, or for the healthy age group of 20 to 30 years old. The latency was that it arrived 18 milliseconds earlier with TSES than with a patellar tendon reflex, and that's just because of the difference in distance from the point of event. Now, there are variation between the healthy group and the TSES part, which we cannot fully explain. We have also found that the first spinal cord injured patient, which is the one with C6, C7 injury, doesn't seem to be totally or complete have a complete spinal cord injury at that level. And on the second patient, the patient with a tumor, he had a substantial longer latency after TSES compared to the others. And here we have some of the numbers. So if we look at, this is the healthy group, healthy young, healthy elderly, then the spinal cord injured at the cervical level, and then the spinal cord injured due to tumor at T1 to T4. And as you see, if you look just at the first numbers, the elderly, they have almost a double mean time for the arrival of the potentials, whereas we have to take into account that there is a high variation in the group. The first spinal cord injured patient, at cervical level, has a normal value for his age, but the spinal cord injury, the second one, has a prolonged time interval for the answer. Now, this was the event related after TSCS. This is then after the patellar tendon test. And here you see that the values are very similar. So it's not the same whether you are stimulating the posterior roots, or if you're stimulating, or if you are hitting the patellar tendon. I don't know why. Yeah, this is just the same numbers, just to make the comparison more clear. And I'll try to go further. Then I come to the event-related desynchronization and synchronization analysis, and we are looking mostly at these 7 electrodes. So it's the CZ in the middle, then FC1 and FC2, C1 and C3 and C4, and CP1 and CP2. And so this is what we get for the TSCS. This is the young, healthy group. This is the elderly healthy group. This is the cervical spinal cord injury, and this is the one with the tumor. And if you can clearly see that, and to explain this, I think I have to explain this a little bit better, or what? Or are you used to analysis of this type? No. Okay. So on the ordinate there is time. He is used to knows all this. Yeah. But for the others, on the ordinate, we have the time, and there is a dotted line which marks the 0 time point. And then we have about 2 seconds, a little bit more than 2 seconds in each box, and maybe half a second before the event. This is, in the direction of nose. This is the direction of left ear, and this is the direction of, this is in the direction of right ear, and this is the left ear, and this is towards the back. And so this is, the event is then a pulse on the spine, transcutaneous spinal cord pulse. And you see that for the young healthy, they are upset. The blue color shows desynchronization, low amplitude, lower than green, which is the base line, the normal activity you get if the people are resting and not doing anything with closed eyes. And so here you get the amplitudes which are lower than the baseline, and here they relax. So we can say that the blue is are representing that the people are alert, and the red one is that they are relaxing again. And you see that the young healthy, they are alerted immediately after the stimulation, and then they relax rather quickly. The relaxation is not as profound by the elderly group. The guy with the patient with a tumor is not so alerted in the beginning, but he relaxes then at a later point of time. this is the same, just in big. And this is after the patellar tendon. Here we see the young, healthy. They have very similar pattern with alert and then relaxing. The elderly, they are alerted but don't relax as well. That is the same as in the former slides. By the spinal cord injured patient, we were hitting on the right leg, but we get an alert on the left side, which is normal. But he was supposed to be a complete. He's clinically complete. But we saw when we were hitting the patella that the thumb was moving. So there was a coupling between the patellar neural circuitry and the motor neuron of the thumb. And this can be seen here. So we consider this as a good result that we can see this connection in the EEG. Okay, I'll be quick as I can. This is the patellar tendon reflex of the same. These are the same actually, and I think I can just go, conclusions and future research. So signal processing pipeline and measurement protocol was developed and tested. Measurement of healthy and spinal cord injured individual performed. Research showed variability within the groups of healthy individuals and between healthy and spinal cord individuals, and signal processing pipeline provides the opportunities to study this further and on a larger scale, and in the end with machine learning, we guess, if we have enough subjects. Okay, I think that's all, as quick as I could. I hope.
Okay.